Good morning, everybody. Thank you very much, David. Thank you very much to the organizers. So my topic will be margins and biomarkers to optimize ablation, as you just heard. Next slide, please. You can see on the next slide my disclosures. I was fortunate enough to receive some research from NIH and industry, especially for the topic we're talking about, ablation and biomarkers. Next slide, please. As you all know, this is particular to colorectal liver mets, but I think it applied to all liver tumors, that indications for ablations have been the tumor size and the tumor numbers. We all know that in terms of ablation, a smaller tumor under 3 cm is the optimal tumor. I'm sorry, now I can't see the slide I'm speaking on. I'm not sure why, but yes, thank you. So we all also know that we can ablate more tumors. It is universally accepted that up to 3 tumors for sure, none of which over 3 cm is acceptable. And a lot of the work we have done within the last 10 years or so has been targeted to which scenarios can ablation probably or possibly replace surgery with the concept of test of time. And I'm going to talk a lot about margins and biomarkers and how these can improve this patient selection and our interventional oncology outcomes. Next slide, please. So through the background, through the history of ablation, there is a very wide variety of numbers of rates of failure, if you wish, or local tumor progression after ablation that have ranged all the way from 2.8 to up to 60% of tumors that have been ablated and then they recur at the same site. So it is extremely, extremely important to understand who are the patients who are going to benefit from this type of treatment, and more importantly, maybe understand if we can find biomarkers or genetics or other factors related to the tumor that can tell us which patients are going to do better versus those who are not going to respond. And this can benefit a large number of patients throughout the world. Next slide, please. So here is a surgical paper in the top of the slide where talked very early on about the value of margin for intraoperative ablation. Again, my slides go back to a different slide than what I'm speaking on. I'm not sure why this is happening, but as you can see, the surgical margin very early on identified that if there is 1 cm marginal around the target tumor or 10 millimeter, the rate of local tumor progression was much, much less than if there was no identifiable margin. And we in radiology thought early on that we had been doing a good job achieving a margin, but when we went back to our results and actually used this information and actually measured the margin, it was very embarrassing to see that the majority of patients we treated, and we thought we treated successfully, actually they had no margin. As you can see here, they were under 5 millimeter margin, the majority. And as you can see, they had a very high local tumor progression at 2 years. Over half of them had progressed, and the area of progression correlated to the area where the margin was very small. Next slide, please. Then this was nothing new. Again, if we go to the surgical literature that evaluated resection, intraoperative laparoscopic ablation, or partial resections, and they actually randomize or stratify, stratify the data by the size of margin, you can see that whenever they had stratification of by margin, there was no difference in the outcomes, no matter what type of resection or ablation it was used. Next slide, please. So the other information that we know is that the surgeons very early on introduced CEA, which is probably one of the very, very common and most widely used biomarkers in their clinical risk score to define how this, in addition to other factors, can impact outcomes. So we can see here 5 elements that create what is known as the surgical or clinical risk score. And for each one of those factors, lymphovascular invasion, disease-free interval under 12 months, more than one liver tumor at the time of treatment, tumor size of 5 cm for surgery, and CEA level over 200 are all giving to the patient 1 point. And then we stratify by the points that they accumulate. You can see here the low-risk patients, 0 to 2, fare much better than the high-risk patients. Next slide, please. So we did the same for ablation, and we dropped the tumor size from 5 to 3, and we dropped the CEA level from 200 to 30. And when we do that, you can see in this cohort of 162 patients, 233 tumors, the results that we got essentially replicate what we know from surgery, with the low-risk patients doing much better, both in terms of PFS and overall survival. So they live longer and they stay without tumor for a longer period of time. Next slide, please. When we went in the same cohorts and we evaluated genetic markers and biomarkers, we saw that the same curve applied to KRAS mutant. So the KRAS mutant is the red curve and is doing much worse, very similar to a high level of CEA. So both KRAS and CEA are biomarkers, they're genetic information and peripheral markers that can actually predict outcomes. Again, I'm off slide. I don't know why this happens, but I'm back to the beginning of the presentation. In addition to that, now can you bring me back, please?
You're on KRAS and CEA, yes?
No, I'm not. Now I am. Yes. Next slide, please. So the other factor that has been recently evaluated, like many other treatments in colorectal mets, is the embryonic origin of the tumor. You can see here, what does this slide tells us, both from Asia and MD Anderson, is that if you have a right-sided tumor, just that information will predict worst outcomes. The red lines and the green lines are worst outcomes, are the high-risk tumors. They are the tumors that are originating from a primary from the right colon. Next slide, please. Now, early on, we started collecting tissue and we tried to see if some biomarkers could predict outcomes after liver and lung ablation. We actually found, next slide, please, that if you have tumor that can be seen at the end of ablation and you apply proliferation marker Ki67, this marker is a marker that indicates that there is DNA activity in the cell, then that marker can actually predict who is going to do better or worse, and that is irrelevant of tumor size, as you can see right here. So Ki67 positive tumors that are smaller will do worse than larger tumors that are Ki67 negative. And this actually was evaluated 10 years later, and we actually saw the impact on survival. You can see here that tumors that had expression of Ki67 after ablation, they had a 5-year survival of 8% instead of 33%. Next slide, please. The same holds for lung tumors that were ablated, and you can see here that the Ki67 markers offers a hazard ratio of 3 for progression, so 3 times the risk for progression, and the same for death from the disease, as you can see on the on your right-hand side on disease-specific survival. Next slide, please. So again, we went back and stratified the data by margin in a larger cohort than we originally did. And actually in this cohort, we had now some tumors that were ablated with even 10 millimeter margins. And then you can see that in addition to the tumor size, the margin plays an incredible role. Next slide, please. Now, measuring the margin with 2D methods, like if you can see the original publications, it's very, very difficult. On the other hand, if we can start using software that have the ability to show the margin in a 3D depiction, we will define a much larger proportion of ablation as incomplete, otherwise no margin whatsoever, and also a smaller proportion as a margin being over 5 millimeters, because an area of the margin that we thought it was ablated ends up being not completely covered at some point in the 3D depiction. Next slide, please. This is a slide that shows how this is done with segmentations that are done either automated or semi-automated. There are several softwares that are done. This work was done here by our medical physicist, Elena Kay, and she published this paper last year in the European Journal of Radiology, showing exactly that this method, next slide please, can detect early on which patients are going to have recurrence and identify actually the area where the recurrence will occur, and that is much more accurate than the 2D method that we described much earlier in 2011. Next slide, please. Now, if you go and look at the data, another factor that has impacted outcomes of ablation has been the known heat-sink effect. And we can see that with radiofrequency ablation, when we see our own data, this is actually pretty true. But when we started using microwave ablation, this is no longer true. And for tumors that are within 1 cm from a vessel that is over 3 cm in size, you can see that microwave ablation has no impact on outcome. The control of the tumor in the long run, local tumor progression-free survival for microwave ablation is the same for perivascular and non-perivascular tumors. Next slide, please. In addition, however, to this, we repeated what we knew about the margin, and we proved that if you can achieve a margin over 10 millimeters, essentially local control was 100%, regardless of whether you use RF or microwave. Next slide, please. So we went forward from that, and with the help of an NIH grant, we started actually prospectively doing a couple of things. One of the standard things we started doing is biopsying the depictable margin, as you can see on the right side bottom of the image. That's an ablation zone, and we're biopsying the margin. And in the left-hand side, we're using fusion PET of the same day, and we're actually biopsying the center of the ablation zone. Next slide, please. By doing that, actually, we showed that if we can achieve, next slide, please, a margin over 5 millimeters, and we prove with the biopsy that that is completely dead, there is no activity, there is no biomarker expression, then the local control at 30 months can be over 97%. That is actually better than any surgical paper that has ever been published for such data. Next slide, please. This is actually a very interesting paper from MD Anderson that analyzes not only the margin that I spoke a lot about, but also the impact of the KRAS mutation that I mentioned earlier on. So what do we see here? We see that if you have a KRAS wild type and you ablate that with a 10 millimeter margin, then your local control will be 100%, no local progression for a very long time. On the other hand, if you have a mutant tumor, they will do poorly. So even if you ablate them well, 17% of those will come back. And if the margin is suboptimal, that number jumps up to 42%. Next slide, please. Same data here, essentially showing the correlation of margin. And this slide actually summarizes that information and shows that both the KRAS mutation and the margins are very, very significant when we're looking at outcomes of local tumor progression-free survival at 3 years. Next slide, please. These are all data from MD Anderson, and they are very similar to our data. These are Memorial Sloan Kettering data that they show essentially the same thing, but evaluated in smaller margins. So what this paper adds to what we already said is that, next slide, please, if you have a narrow margin, then your control of the mutant tumor will drop to the same control as tumors that they were not treated at all. So if you're going to do a narrow margin on a KRAS mutant, your risk for recurrence is 17 times that if you're doing a wild type tumor with a margin over 5 millimeters. So the conclusion here is that if you cannot ablate it with a minimum of 5, you shouldn't touch it. Next slide, please. Now, there are a lot of limitations in imaging, and we're talking about margins, but a lot of the problems we have is actually imaging these tumors before and after ablation. Next slide, please. There is a lot of publications on what is an ablation zone and how it should look. So this is an ideal scenario where you see a triple phase CT before and after the ablation. The portal venous phase is the most valuable for METs. The arterial phase is much more valuable for hypervascular tumors like HCC, but the end game is the same. The ablation zone should completely cover the tumors with a nice margin that should be evaluated not only the same day, but within 3 to 8 weeks after ablation. This is 6 weeks after, which is our routine in my place. Next slide, please. Next slide, please. Of course, yes, RECIST is useless. And here is a slide that actually shows how we improved outcomes when we started just simply mandating a contrast-enhanced CT after ablation. This started with the ground that we were doing the biopsy, but this outcome is for all comers, and it shows that from the moment we started implementing a mandatory contrast-enhanced CT the day of the ablation, our margins got better and our outcomes got better because the people were getting a visual identification of their ablation zones. Next slide, please. Okay, next slide, please. We're not going to stay on that. So next slide here shows the complete lack of identification of a PET-avid tumor that was not seen at all within the ablation zone. We only suspected it by the CEA that was rising, and eventually there was a PET-avidity within the ablation zone, and shows the value of metabolic imaging in this type of treatment. Next slide, please. This was biopsy-proven recurrent tumor within a surgical intraoperative ablation site. Next slide, please. And shows the value of PET that has been shown over small but several publications that is much more sensitive, of course, than CT. And even in many times, it can be more sensitive than MRI. Next slide, please. This is particularly true. Next slide, especially when you have post-ablation findings and you're trying to discriminate which is what. So we strongly recommend the use of PET, especially for PET-avid tumors like breast, colon, and so forth. Of course, this is not as value for HCC. Next slide, please. Now, again, this slide says that it's not a matter of using one versus the other. We strongly recommend the PET again for those that are PET-avid prior to, but a combination of MRI and PET, it's really important, and we in interventional oncology have to really work hard to prove this to the rest of the medical society and the insurances that very often gives us hard time when we're trying to do this imaging to detect recurrences after treating a tumor. So think about that and try to establish that and use the papers that have already been published to evaluate your ablation zones and insist with your insurance companies. Next slide, please. Again, the same. If you do that, you can use the PERSIST criteria, which is a modification of the RECIST, adding SUV changes to the tumor size changes. And it's good to know those because they can very early on detect progression after a treatment of a PET-avid tumor. Next slide, please. Again, this tells us that in about 82% of cases in surgery, the use of PET actually changed management of the treatment that was offered to the specific patients. Next slide, please. Here is a method that we have been using at Memorial, using metabolic imaging in real time. So we are using 1/3 of the dose prior to ablation. We do the ablation, and then at the end, we re-inject the patient with 2/3 of the diagnostic dose to allow us to see if there is any residual tumor that was not ablated. These scans can be done within 30 minutes from the injection of the FDG. Next slide, please. Using this method, we have managed to do fusion and show the ablation zone and margin, and we have also been able to do biopsies, as I said earlier. Next slide, please. In addition to that, we did a lot of research showing whether the SUV after ablation can be used as a surrogate imaging biomarker. This work was done by Francois Cornelis, which is now in France, and he found out that tissue radioactivity concentration can be a surrogate image biomarker of early recurrence within 12 months from ablation. Next slide, please. It's hard to say which number would determine that, but you can see here the immediate post-ablation images with a very low SUV, very low TRC. This is a good predictor that you're going to have good control of disease at 12 months. Next slide, please. On the other hand, if immediate post-ablation signal goes up, as you can see here, that's a bad predictor, and it tells you that there is a high chance of getting a recurrence within 12 months from ablation. Next slide, please. The magic number that Francois found that makes the difference is a TRC number of 27.8, and that provides an accuracy of about 88%, as you can see here. Next slide, please. So next slide, please. Nothing much here, but here is extra work that Francois went ahead and do. And in this work, he added to his SUV and tissue concentration radioactivity ratios the value of biopsy. And what he found, next slide please, was that SUV was of course higher when margin and viable tumor were present. But the important information here was that in a subgroup where the biopsy was negative for proliferating tumor at the end of ablation, a minimal margin under 5 and a high SUV ratio were both independent predictive biomarkers of the early local tumor progression, at least for colorectal mets. Next slide, please. Next slide, we talked about this. This is a duplicate, it's nothing new. So we used all this information in a grant that we were able to obtain from the NIH via the R01 mechanism, where we put all this together and we are actively recruiting. Next slide. So this slide allows us to do PET-guided ablation for colorectal mets. As you can see here, we combine 3D depiction of the ablation zone intraoperatively, and then we are doing 2 steps at the end. One is an imprint cytology to actually see tumor cells or not, or burn tissue, and then immediately we also do a mitochondrial investigation with these fancy fluorescent stains that can tell us whether the mitochondria are active or not. Next slide, please. This study is also biopsying the relatively high SUV rate, trying to actually correlate the exact amount of SUV with the possibility of tumor left behind. Next slide, please. And this is actually the conclusion. We can conclude that biomarkers, especially the CEA, a very old biomarker that has been applied in the clinical risk score, is an important factor impacting outcomes of thermal ablation, especially for colorectal liver mets. Clinical and imaging follow-up is mandatory for the early detection of recurrence. A minimal margin of 10 millimeters is established as the optimal margin, and it can provide for a very long, sustained control. You can see there over 95 local tumor control for over 2 years. A 5 millimeter margin is the absolute minimum, especially if you're offering ablation with curative local intent. Know the genetics, know the embryonic origin of the tumors. These are all factors that come into play for each disease. We know for colorectal cancer, embryonic origin from the right colon, mutation of the RAS gene, mutation of the BRAF are all poor indicators of outcomes. Especially if you have a RAS mutant, it's essential that you make sure that your margin is over 5. Ideally, you want them over 10 if they are in a location that this is safe. But if you cannot achieve that, there is no reason of offering this type of treatment. Thank you very much. Next slide, just to remind us that we are with SIO, and I'm memorializing here SIO 2020, which was probably the last meeting we all met in person, and we're looking forward to that to happen in the future again. Again, thank you very much, and thanks for the organization.